Dr. Jayasheela, Associate Professor, Department of Pharmacology, working in films. So today I'm going to discuss about pharmacotherapy of migraine. So I'll start with a case presentation. A 36-year-old lady presented with a unilateral pulsatile headache for the past 2 years. So during the initial episodes, the headache was mild and relieved by paracetamol or ibuprofen tablets and did not interfere with her daily activities. However, the severity and frequency of the pain episodes has progressively increased so that now episodes recur nearly 1 to 2 weeks, especially at the beginning of her periods. Headache is preceded by lethargy, anorexia, nausea, and is accompanied by blurred visions, flashes of light seen on closing the eyes, unsteadiness, and frequent vomiting. The pain lasts for 12 to 18 hours, and she is incapacitated for nearly 24 hours. The headache is relieved by over-the-counter drugs. So this case study tells us that initially her daily activities does not interfere when she takes NSAIDs such as paracetamol and ibuprofen, and later the severity is increased. So she is developing headache, blurred visions, and flashes of light, and it stays for 24 hours. So the headache is relieved by the over-the-counter drugs. So what is this presentation? What is the case study is telling us? It is a migraine. Now we are saying that it is a unilateral pulsatile headache, and so the main thing is headache is preceded by lethargy, anorexia, nausea, and accompanied by the blurred visions. So it tells that so there is a symptom which is preceded before the headache. Okay, so that is called as the aura. Aura is nothing but it is some symptoms which will tells us that she or he is going to get a headache. Okay. So what is a probable diagnosis? So we said that it is a migraine. What medication can be prescribed to treat the headache episodes? So these are my objectives. What is a medication you can be given? And what specific medical history needs to be elicited? Physical examination, investigations performed before prescribing the above medications. Apart from treatment of pain episodes, can this patients to put on some regular medication to prevent or minimize episodes? It means that the fourth point is it means that there is a prophylaxis. Is there any prophylaxis can be given to prevent the attack of headache? So before going to the treatment of migraine part, so we'll discuss about serotonin, because serotonin is a hormone which is majorly involved in the migraine. So we know that vasoconstrictor is a serotonin and enteramine. Serotonin is otherwise called as a 5-hydroxytryptamine. It is a monoamine neurotransmitter. It is a biochemically, it is derived from the tryptophan. So it is a feeling of well-being. So it is present in the intestines, especially 90% along with the platelets, and brain 10%. So in this case, we have said 90% in the interior chromatin cells and 10% in neurons of different plexus, which is also being stored in the granules like catecholamines. It is also present in the plants and insects. So plants like tomato, banana. So normally we used to take the fruit. Commonly taken the fruit is banana and pineapple. And lower animals like molas, arthropods, snake, and bee venom or sting. So synthesis of serotonin. So it has been derived from the L-tryptophan with help of a tryptophan hydroxylase. So L5-hydroxytryptamine is converted to the 5-hydroxytryptamine with the help of a aromatic L-amino decarboxylase. And 5-hydroxytryptamine it has been converted to 5-hydroxyindoleacetaldehyde with the help of a monoamine oxidase. And with the help of aldehyde dehydrogenase, this 5-hydroxyindoleacetaldehyde is converted into 5-hydroxyindoleacetic acid. And what are the receptors which is present? So we is called as the autoreceptor. What is maybe autoreceptor? It is a 5-HT1A. What is maybe autoreceptor? You have any idea? So autoreceptor is nothing but it automatically control the release of neurotransmitters. So this release and inhibition has been done automatically. So that's called as the autoreceptor. So that will inhibit the serotonergic neural activity in the brain. So the most common serotonin autoreceptor is a 5-HT1K, which is present in the raphe nuclei and hippocampus. So buspirone may act through this receptor. And 5-HT1B or 1B, which will constrict the cranial blood vessels and inhibit the release of inflammatory neuropeptides in them. And somatropin acts through these receptors. So the most common receptor which we want to know in migraine condition is a 5-HT1D and 1B receptor, because the somatropin is a drug which has been used in the migraine, which acts on the 5-HT1D receptor, because that receptor causes a constrict the cranial blood vessels and inhibit the release of inflammatory neuropeptides, because the pathology of migraine is mainly due to the dilatation of the cranial blood vessels. Okay, so this receptor which causes constriction, so somatropin acts through this receptor. And 5-HT2A receptor is the most important post-junctional receptor mediating direct action of 5-HT like vascular and visceral smooth muscle contraction, platelet aggregations, and neuronal activation in brain. And 5-HT3 emesis, gut peristalsis, bradycardia, so treatment hypotension, so apnea, pain, itch. So ondansetron, we know that is a 5-HT3 receptor blocker, so which is being used as antiemetic agent. So mainly it blocks this 5-HT3 receptor. And 5-HT4, it will also augment the peristalsis. So we always remember the pride which will augment, which has got agonistic action on the 5-HT4, like rinsapride, mosapride, cisaprides. All prides are agonistic action on the 5-HT4 receptors. What is the pathophysiological role? So the neurotransmitters, we know that it is a confirmed neurotransmitter in the brain cells containing 5-HT is present in the rough nuclei of the brainstem substantia nigra. This appears to be involved in the sleep, temperature regulations, thought processes, cognitive functions, behavior, and mood, appetite, vomiting, and pain perception. It's also a precursor of the melatonin. So 5-HT is a precursor of melatonin in the pineal gland. It is believed to regulate the biological clock and maintain the circadian rhythm. Nausea and vomiting, especially that is evoked by the cytotoxic drugs, especially the platinum group of drugs like cisplatin, carboplatins. So those drugs are, it is a highly antiemetic, highly emetogenic anti-cancer drugs. So those drugs cause a severe vomiting. So what we have to do is we have to give antiemetic agents before you start anti-cancer agents. Okay, so the most common drugs which has been used for the to prevent the cancer-induced vomiting is anti-cancer-induced vomiting is ondansetron. That's good, especially that is evoked by these cytotoxic drugs or radiotherapy, which is mediated by a release of a 5-hydroxytryptamine and is action on the 5-HT3 receptor in the gut area posterior and nucleus tractus solitarius. So we know that we have discussed in the previous slides that is a 5-HT3 receptor antagonist is what? Ondansetron, which can be used before giving anti-cancer agents. Migraine. So 5-HT is said to initiate the vasoconstrictor phase of migraine and to precipitate in the neurogenic inflammation of the affected blood vessels. Hemostasis, platelet release 5-HT during aggregation at the site of injury to the blood vessels. So it will acting in concert with the collagen and other mediators, and this phytohydramine accelerates the platelet aggregations and clot formations. So neuroendocrine functions is the hypothalamic neurons that control the release if anti-repetitive hormones are probably regulated by a serotogenic mechanism. Variant angina is release of hydroxytryptamine from the platelets has been implicated in causing a coronary spasm and variant angina. So what are the receptor antagonists? So 5-HT2 receptor antagonist is called ciprofloxacin. So it is a histamine HL receptor blocking as well as a 5-HT2A blocking actions. It is also used as a anti-muscarinic effects and causes a sedation. It was clinical uses. It is a appetite stimulant to promote a weight gain. It's mostly commonly given for the children, not eating properly and malnourished child. So in such cases, you can use a ciprofloxacin. It is available as drops preparations and syrup formulations. So this can be given before a food. Clozapine is an atypical antipsychotic drug. It is a 5-HT2A2C receptor antagonist with a high affinity for a dopamine receptor. So what is the advantage of this clozapine is it will reduce the incidence of extrapyramidal side effects compared to the classical antipsychotics. So greater efficacy for reducing negative symptoms of schizophrenia. High antagonist is ondansetron, so it is useful in the treatment of a chemotherapy-induced nausea and vomiting. And its also other drug is called as a risperidone. This is also an atypical antipsychotic. This is combined with the 5-HT2A plus dopamine D2 antagonist. So up to now we have discussed about the serotonin receptors and what are the drugs which has been involved and what are the drugs which will inhibit or it will what an agonistic action on the serotonergic receptors. So now we are going to move towards the what is a migraine treatment and what is a migraine. So what is a migraine? It is a repetitive kind of throbbing headache that typically affects one side of the head and is often irritated with nausea and unclear vision. So one is suffering with a migraine if in his lifetime there have occurred 6 or more attacks of unprovoked headache lasting for 4 to 72 hours. It is a tough enough to markedly restrict or even cause a problem in a routine daily activities. So what are the causes of the migraines? What are the possible causes which will provoke a migraine? So lots of stress. Nowadays we are facing lots of stress, depressions, lack of sleep, especially during the COVID period. So most of them developed economically crisis. So they'll end up into the stress and the depressions, lack of sleep, tiredness, and poor sitting posture because of the obesities, overexertion of body, skipping a meals, and lot of noise. So these are some of the probable causes which will cause a migraine. What are the symptoms of migraine? So pain on one side of the head or both sides of the head. It is inability to perform regular activities due to pain, feeling sick, and they may have a physically vomiting. Especially they have the cases we have seen what headache and they are preceded with the vomiting. Blurred vision will be there. They have lightedness, sometimes followed by a fainting, depressions, frequent yawning will be there. Mood changes sometimes even leading to the depression. What are the different types of headaches? So the patient comes with a headache. We should not go to the conclusion that patient is having a migraine. So you should have some differential diagnosis of a headache. So the main thing is sinus. So sinusitis is the most common conditions patients come with a headache. So sinus pain is usually behind the forehead or even the cheekbones. So you can examine by pressing a sinus. So if the patients develop any pain and pressing on any tenderness, so we should have some differential diagnosis on the sinusitis and cluster headache. There is a pain is in and around the eyes called cluster headache. And tension is a pain is like a band squeezing the head. So migraine is a pain. They should have nausea and they will have a visual changes or typical of a classical form. So it's otherwise called as a classical migraine. So they'll have a pain. They'll have a headache. And there may be a nauseating symptoms or they may vomiting and they may have a visual disturbances like blurred visions. So this is a typical form of a classical migraine. And what are the types of migraines? We have discussed that is a with aura and without aura. I have discussed that what is meant by aura. Aura is nothing but it is a symptoms which will come before the headache. Okay, so they'll feel like because by seeing by hearing noise or seeing any flashes of light, okay, or during especially females during just before their periods. So these are some symptoms which will give a signal to our body, will signal to us that she or he is going to develop a headache. So that is called as a with aura. And without aura means so they don't proceed with any symptoms. So they'll get a headache just like that. So it is divided into complicated migraine and we have a common migraine. So what is a common classical migraine is in which headache is preceded by any visual or other neurologic symptoms. It's called with any aura. It is called as a classical migraine. What is a common migraine means? It is a migraine without aura. So aura means I think we have discussed it is a perceptual disturbance experienced by some migraine sufferers before a migraine headache. It is a pulsatile dilatation of the certain cranial vessels. It's the immediate cause of the pain. So this is some of the example of visual symptoms. So there are some theory which has been postulated that maybe due to the pathology of a pathophysiology of a migraine. So the first theory is the vascular theory. It means that it holds the initial vasoconstriction or the shunting of blood vessels through carotid arteriovenous anastomosis is producing a cerebral ischemia and develops a attack. So there may be a vasoconstriction, initial vasoconstriction, or there is a blood will get stagnated in the atrial venous anastomosis. Okay, so because of the stagnation, what happens? The blood will not go to the brain. So they may develop a cerebral ischemia, they develop an attack. That is one of the theory, vascular theory. Another theory is a neurogenic theory. So there are some triggering events appears to produce a neuroinflammations of the affected blood vessels, which is amplified by a retrograde transmission in the afferent nerves and release of mediators like tryptophan, substance P, and nitric oxide. So because of the release of neuroinflammators, so that may cause a inflammation of the vessels. Okay, so that will end up into the attack. So let's classify it into mild, moderate, and the severe migraine. So first, we'll start with the treatment of mild migraine. How will you start with the treatment of? So it is a mild migraine patients mainly with the mild symptoms, or so the symptoms will get reduced within a few hours. So in such cases, you can start with a simple analgesis. What is a simple analgesis? You can give paracetamol. So normally aspirins we will not prefer for the migraine. Okay, so we'll start with the paracetamol. We have a lots of preparations. We have 250 preparations. We have 500 preparations. We have a 650, and we have 750, and we have 1000 milligram. Okay, so according to the body weight, you can calculate. You can give a paracetamol. It's taken at the first indication of an attack. When the patient comes to the first attack, they can take a paracetamol and repeat a 4 to 6:30. If it is needed, you can take a 4 to 6:30. And this will abort and suppress most of the mild attacks will be aborted when you give a paracetamol. So this is a simple analgesic. And NSAIDs combinations, if the patient has not been controlled with the paracetamol, what could be the other choice? So you can start with the NSAIDs plus combinations you can give. That is called ibuprofen plus diclofenac or indomethacin, either alone or combined with the codeine. So diphenhydramine or sedative or antihistamines. So we can give a NSAIDs. So patient will respond better. So these drugs are more effective in migraine without ARA. Okay, but certain patients of migraine with ARA also prefer them over a triptans. And also antiemetics. As I said, the patient will have a headache, and also they'll have a vomiting will be there, nausea, vomiting will be there. In such cases, you can give there may be gastric stasis occur during a migraine, so which would delay the absorption of the oral drugs. So metoclopramide is frequently used to relieve the nausea, vomiting, and gastric stasis. So patients already vomited, so it is better to give a antiemetic by injection. So remember, routes of administration is very important. Okay, what route, which time you are giving a what route is very important. Okay, so patients with the severe vomiting, so if you give a oral and ondansetron, oral metoclopramide, the patient again she'll vomit. So drugs will not act. So prefer a intramuscular intravenous route, okay, rather than a oral route. So this is about your antiemetics. And moderate migraine. What is a moderate migraine? It's a throbbing headache. It is more intense. So they have a more pain will be there, which is lasts for 6 to 24 hours. So patients have pain up to 24 hours. So they also present with the nausea, vomiting, and other features are more prominent. And when the patient is functionally impaired, so they can't do anything. Okay, so the household that there is a daily routine activities which has not been performed. Okay, so patient have a severe nausea and vomiting because headache will last for 24 hours. And also the 1 hour more attacks per month. So in 1 month they have a 1 hour more attacks. So in such cases, the simple analgesics are usually not effective. What a simple analgesic we have discussed? What is that? Paracetamol you can give, and any NSAIDs can be given like ibuprofen, diclofenac, aceclofenac, anything else. So you can add on. So in such case, then not at migraine, that simple analgesic are usually not effective. So but stronger NSAIDs or their combinations are beneficial. So you can start the pyroxicams. Okay, so stronger NSAIDs can be preferred. And in these conditions where the patient has not been responding to the NSAIDs, you can add on with the triptans. What are the triptans we have? Sumatriptan is there. We have triptan is there. Okay, so we can add triptans can be added. What is severe migraines? Means the patient suffer 2 to 3 or more attacks per month of severe throbbing headache lasting 12 to 48 hours, often accompanied by the vertigo and vomiting. So there is more attacks will be coming per month. Severe headache will be there, and also they have a vertigo, they have some dizziness, they may have a vomiting will be there. So NSAIDs or analgesic and their combination usually do not afford relief. Specific anti-migraine drugs to be preferred. So we can add a naproxen plus triptan. So naproxen is a stronger NSAIDs which can be given like pyroxicam. Naproxens can be given along with the triptans. So prophylactic regimen should be given for 6 months or more recommended. Why? Because the patients end up into the severe migraine. So they may get an attack every month. Okay. So that because we discussed it is a 2 to 3 attacks per month. So in such cases, not responding to the simple analgesic, it is only respond to the stronger anti-inflammatory plus triptans. In such cases, we have to add on a prophylactic therapy for 6 months. So these are the drug therapy of migraine. So severity, what is the drug we can use? Simple analgesic or NSAIDs of their combinations, plus or minus antiemetics. Moderate NSAIDs combinations, triptans or ergot alkaloids, antiemetic plus prophylaxis. Needed, we can add a prophylaxis. Not controlled with NSAIDs with the triptans. Severe is a triptan plus antiemetics plus prophylaxis such as propranolol or either amitriptyline or flunarizine or valproate or topiramate. So this is the drug therapy of a migraine. And the most thing is ergotamine. What is it, ergotamine? It is the most effective ergot alkaloid for migraine. It is given early in attack. Relief is often dramatic and lower the doses suffice. But when pain has become severe, larger doses are needed and control may be achieved only after few hours. Oral or sublingual route is preferred. So 1 milligram is been given at half an hour interval till relief is obtained, or a total of 6 milligram is been given. So you can start with a 1 milligram every half an hour, or total you can give a 6 milligram. So what is the parenteral administrations? Though rapid in actions is a more hazardous. So normally they prefer the ergotamine in a oral or a sublingual route. What is the mechanism of action? So ergotamine acts by constricting the dilated cranial vessels or by a specific constriction of the carotid arteriovenous shunt channels. Because we have discussed that what is the vascular theory of migraine? So the vascular theory of migraine is a specific dilatation of the or shunting of blood in the carotid arteriovenous blood vessels, right? So this ergotamine what does this? So opposite to the pathology. So pathology is dilatation, right? Here it is constrict the carotid arteriovenous shunt. And ergotamine and dihydroergotamine have also been shown to reduce neurogenic inflammations and leakage of plasma and neuromatter. So we have also discussed the neurogenic theories, that is a release of there are some triggering factors which will release the neuroinflammatory mediators like substance P. Okay, and so that inflammatory mediators has also been inhibited by giving a ergotamine. So dihydroergotamine is preferred for the parenteral administration because injected of dihydroergotamine is less hazardous. So plain ergotamine, what is the formulations we are using? So we are using as oral preparations and the sublingual preparations, and there is other preparations for dihydroergotamine which can be given as a parenteral administration. So what is the current status of this ergotamine is because of the erratic oral absorption and frequent side effects, especially nausea, vomiting, muscle cramps, and availability of triptans, these ergot preparations are rarely used. So it can be this got a benefit over the benefit actions like such as the constriction of the specific shunt carotid arteriovenous blood vessels, and there is inhibition of the neurogenic inflammatory mediators. Okay, because of these absorption and also because of what adverse effects such as vomiting, muscle cramps, and also there is a availability of triptans will reduce the use of the ergotamines in case of a migraine. What is a triptans? Sumatriptans are selective agonists of 5-HT1B and 5-HT1D receptor. So activation of this 5-HT1 receptors leads to what? So sumatriptan causes constriction of the dilated cranial extracerebral blood vessels, especially the arteriovenous shunt in the carotid artery, which expresses 5-HT1B and 5-HT1D receptors. So why this drugs are common? Because these are receptors like 5-HT1B and 1D receptors is more commonly expressed in, it is more commonly expressed in the carotid arteries. Okay, and 5-HT1D and 1B is autoreceptor. So what happens is it will reduce the hydroxytryptamine release automatically. So dilatation of these shunt blood vessels during migraine attack is believed to divert the blood flow away from the brain parenchyma. It can also reduce inflammatory neuropeptide release around affected blood vessel and extravasations of plasma proteins across dural vessels. So extravasations, nothing but this exudation of the blood lymph from the vessel into your tissues. And triptans have been found to suppress the neurogenic inflammation of the cranial vessels. So apart from the constriction of the specific carotid arteriovenous shunt, it is also reduces the release of inflammatory mediators. Use of triptans are restricted to the moderate or severe attack, which is not controlled to the analgesics. Okay, so if the patient has not been controlled by a simple analgesics like your paracetamol or NSAIDs, like even naproxen, you can use triptans are only restricted to their conditions. So triptan is sumatriptan is an indole compound. It also suppresses the nausea, vomiting of migraine, whereas ergotamine increases these symptoms. So because we have discussed what? We have discussed ergotamine itself, which causes a nausea and vomiting. Okay, but sumatriptan suppresses the nausea and vomiting, so that this is a preferred drug over a ergotamine. It is also better tolerated than the ergotamine. So 3/4 of the patient obtain a significant relief from the headache within 2 to 3 hours when compared to the ergotamine. So out of 4 patients, 3 patients they develop a significant relief from the headache. And also subcutaneous preparations are also available. You cannot take orally. So 6 milligrams subcutaneous given within 10 to 20 minutes is a more consistent, effective. Nasal spray is also available. It produces a rapid actions. Sumatriptan and ergotamine should not be administered within 24 hours of each other. So the ergotamine has been given means you have to wait for the 24 hours. So then only you have to start with the sumatriptan. What is the adverse effects of the sumatriptans? So the main thing is tightness of head and chest. Fullness of head will be there. Paresthesia in limbs, dizziness and weakness, short lasting, and so it is mostly these adverse effects are short lasting and dose later side effects. So once you reduce the dose of the drugs, so these symptoms will get rid of. Okay, slightly rise in the BP, clinically insignificant. A serious but infrequent ADR is a bradycardia, coronary vasospasm, and hypersensitive reaction. So that's what you have to ask the history. So patient history is very important, and you have to ask a medical history whether the patient is a ischemic heart disease patient, IHD patient, or the patient is taking any hypertensive drugs, antihypertensive drugs, or your patient is a anginal patient. Okay, so you have to ask the history. So if at all this coronary vasospasm is there, you have to be very careful. So what is a contraindication? That's what ischemic heart disease, because coronary vasospasm is the most common adverse effects of sumatriptan. Hypertension is the epilepsy, hepatic or renal impairment, or during pregnancy. These are the contraindications of the sumatriptan. So what are the other analogs of the sumatriptans? So zolmitriptan, rizatriptan, almotriptan, fravatriptan, naratriptan. So differ in the pharmacokinetic properties. So naratriptan is a bioavailability is only 70%. So t-half for 6 hours. It is largely excreted and changed in the urine. And prophylaxis of migraine. What is prophylaxis of migraine? So mostly we give for the severe cases, and also in moderate where the patient is not responded. In such cases, you can give a prophylaxis of migraine. Okay. So regular medication is recommended for moderate to severe migraine when 2 to 3 attacks per minute. So in such cases, if the patient is put on a prophylaxis, it not assess the patient has to take only prophylaxis. So they should also take a regular medication with NSAIDs and also triptans. Diverse class of drugs are used, but none is effective in all places, and none abolishes the attack quickly. So most variety of classification of drugs has been used. So it is not as effective and also it does not abolishes the attacks totally. It is advisable to discontinue prophylaxis every 6 months to check whether a continuation is needed or not. So we have to stop the prophylaxis after 6 months. We have to look for the patient, whether the patient developing headache or not, whether the migraine is being repeating or not. Okay. So what are the prophylaxis can be given? The most common drug which is used for the prophylaxis of migraine is a propranolol. It's the most common for continuous prophylaxis drug for a migraine attack preventions. And also amitriptyline, it is a tricyclic antidepressant. So the dose is a 25-50 milligram. It is most frequently used. Valproic acid, we know that it is it is a broad spectrum antiepileptic agents. Dose is a 400 to 1200 milligram, which is effective in decreasing the migraine frequency. NSAID is used to attack the prevention and aborting the acute attack. Beta adrenergic blockers. So propranolol is the most common used drug. It reduces the severity by 70% of patients. The starting dose is a 40 milligram twice daily, and 160 milligram daily twice daily. So we can start from 40 to 160 milligram. The mechanism actions are not clear. Tricyclic antidepressants, it's amitriptyline. So we can give it a bedtime of 50 milligram. It is the most expensively tried drug, reduces the migraine attack. It is the best suited for the patients who suffer from the depressions. In 2-in-1, because you can give for a depressant, antidepressant also you can give, and it's also used for the migraine. It produces more side effects than propranolol. And there's a calcium channel blockers. Verapamil is less effective than propranolol, but there is a weak calcium channel blockers. It's a flunarizine. It is the most commonly used with the combination with the triptans. So flunarizine is relatively weak calcium channel blockers that will inhibit the sodium channel. Gabapentin, valproic acid have a prophylactic role in migraine. 50% reduction in attacks in half patients was noted. Efficacy of anticonvulsants is less than the propranolol. So they are indicated in the refractory cases or where the propranolol is a contraindicated. In such cases, we can use anticonvulsants. So this is about the treatment part and migraine part. So what are the two things which we have discussed in this class? So we have discussed about what is serotonin. We have started with the case study and we have discussed the serotonin part and what is the receptor which has been involved and what is autoreceptor and what is the receptor which has been extensively present in the carotid artery and what is the drug which is used for the migraine and what is the category of the drugs which is used for the mild, moderate and severe cases and what is the mechanism action of sumatriptans and what are the drugs which is being used for the prophylaxis of the migraine and what are the various classification of drugs that's being used for the prophylaxis of the migraine we have discussed. Okay, at last we have come with the MCQs. Okay, so what is the first question is about 90% of body content of 5-hydroxypyridine is located in brain. So what is the option? The option is the A, enterochromaffin-like cells of stomach and intestines. Tachyphylaxis to many actions or repeated injections is a feature of a following article. It's a 5-hydroxytryptamine. So the following is a selective 5-HT1D is a receptor agonist. What is that? 1D receptor antagonist is a sumatriptan. The following serotonergic receptor functions primarily as an autoreceptor on neurons is a 5-HT1A. So 1A is a autoreceptors. The non-steroidal anti-inflammatory drugs are more effective in migraine, so with the aura. Ergotamine, not necessary that with aura also you can give a NSAIDs drugs because no other choice, you have to give a NSAIDs. Ergotamine relieves migraine by what? By constricting, the option is D, constricting the cranial vessels and reducing the perivascular neurogenic inflammation. The calcium channel blockers used for the prophylaxis of migraine, which is used in the angina pectoris, not used in angina pectoris. So what is the drug is flunarizine. What is the prophylactic therapy of migraine, which is recommended in all cases? Benefit up to 70% of patients of moderate to severe anemia, so severe migraine, need to be continued lifelong. Reduce the severity but increase the frequency of migraine. What is the option? The option is B. It benefits up to 70% of a moderate to severe migraine. So what is antidepressant is beneficial for migraine? What is the option? So the option, very good. The answer is a C. Amitriptyline is a antidepressant which can be used for a migraine as a prophylaxis. Which of the following drugs is the most commonly used for prophylaxis of migraine? What is the drug? Very good. The option is a B. Propranolol. So thank you. So this is about your pharmacotherapy of migraine. I hope you all understand it.